Hi, welcome back. It's Andrew Penn, and this is the third and last section of the treatment-resistant depression module. In this particular module, we're going to talk about switching medications. So when we've decided a medication isn't working, how to switch. And we're going to look at some of the more uncommon medications such as tricyclics and monoamine oxidase inhibitor antidepressants, or MAOIs, and think about the safety for those particular medications. And we'll also consider the question of when we might want to refer for ketamine, which is something that we'll talk about in more detail in the psychedelic assisted therapy section. So the first thing I want to talk about here is the atypical antidepressants. Now, the atypical antidepressants, I sometimes like to think particularly of mirtazapine as kind of being the psychopharmacologist's secret weapon. Now, this category includes trazodone, nifazodone, a drug called monanserin, which isn't available in the United States, and mirtazapine. And one of the things I like about mirtazapine in particular is that it has side effects of causing drowsiness and causing increased appetite, which sounds terrible unless your depression has rendered you unable to sleep and losing weight because you've lost your appetite. The other thing I like about mirtazapine is that it has minimal sexual dysfunction associated with it. The mechanism of action of the atypical um, antidepressants is a little more complicated. They are not monoamine reuptake inhibitors. Okay, so they're not SSRIs, they're not SNRIs, they're not NRIs. They have receptor activity and they serve as receptor antagonists at alpha 2, histamine 1, serotonin 2A, 2C, and serotonin 3 receptors. Now let's take a look at what that does. So in mirtazapine, mirtazapine will plug into the noradrenergic alpha 2 receptors, okay, as an antagonist. And specifically, that when they're functioning as autoreceptors. So autoreceptors you can think of as sort of like your thermostat, how your thermostat works with your heater. Your heater doesn't really understand what temperature is. It just understands I either make heat or I don't make heat. Your thermostat understands temperature, and it says when I get enough temperature in this room, I'm going to tell the heater to stop making heat. Well, an autoreceptor is kind of like that thermostat. What it does, it sits on the presynaptic neuron, as you can see there, and when it gets saturated with enough of whichever neurotransmitter, in this case norepinephrine, it is sensitive to, it will tell that presynaptic neuron to stop releasing that neurotransmitter. So what mirtazapine does in part is it blocks that alpha 2 noradrenergic receptor. And so it works sort of like putting a box over the thermostat so the air can't reach it. So what happens is the synapse keeps pumping out norepinephrine, and that is thought to improve mood. Additionally, the mirtazapine blocks these alpha-2 somatic dendritic receptors in serotonergic neurons, which actually causes increased serotonergic release. Additionally, it works like an atypical antipsychotic in part in that it blocks the serotonin 2A receptor and also the serotonin 2C receptor, and these are also associated with antidepressant response. And then finally, it works as an antagonist at the serotonin 3 receptor in the chemoreceptor trigger zone in the brainstem. And this may sound familiar to you if you've ever given ondansetron or Zofran, because that's exactly how that particular drug works. So this may be why mirtazapine is associated with less nausea than other antidepressants. Now let's take a look at a couple more recent antidepressants. So vortioxetine is probably the newest antidepressant on the market other than esketamine. And this is essentially an SSRI that has antagonist effects at serotonin 3. So again, similar to mirtazapine in that it probably helps to reduce nausea. It also has antagonist effects at serotonin 1D and serotonin 7. It's an agonist at serotonin 1A, so similar to buspirone, and it's a partial agonist at serotonin 1B. The dosing is usually 5 to 20 milligrams a day, and it may have a somewhat lower incidence of sexual dysfunction than other SSRIs. Now, how effective is it? Well, if in this meta-analysis, if you look at, so if you are not familiar with how to read one of these, you want to take a look at this center line. And essentially everything to the right of it favors the drug in question. Everything to the left of it would favor the drug that it's being compared to. If you look at the bottom, you can see it's markedly superior to placebo, as it should be. And so the further away we get from the line, presumably it's more effective. So when we take a look at this, we'd say it's the thing that's probably most competitive with would be bupropion. The drug that it is least likely to be better than would be escitalopram. So, reasonable benefit. The Cochrane um, organization said that it certainly beats placebo. It's not known how much better it is than SSRIs, and it's probably about as effective as SNRIs, and probably actually less effective than duloxetine. So it's another option that's out there. It is still branded at the time of this recording, so it will be expensive until it is off patent. The Lazadone is this probably the second oldest and more recent antidepressant. Take that back. It's been out about 10 plus years now. And this is essentially an SSRI with a serotonin 1A agonist built in. So a lot of people said this is like taking an SSRI with buspirone. Dosing goes 10 to 40 milligrams. And if you look at this forest plot here, you'll see that it didn't do as well compared to a lot of existing antidepressants. Really, the only thing that it had any and even marginal superiority to was bupropion and fluoxetine. But otherwise, the other existing drugs actually did better. But again, another option, I believe, is still branded, and so therefore expensive. What about tricyclic antidepressants? Now, this is something that a lot of people have kind of gotten out of practice with using because they have been around for a long time. These were the antidepressants that existed before Prozac, and so they were commonly used in the 1960s and 1970s and the first part of the 1980s. And they are certainly effective antidepressants. The problem is they have a lot of side effects and they are lethal in overdose because of their potential to cause cardiac arrhythmias. So it's important anytime you start a tricyclic antidepressant to take a cardiac history. You're going to want to get an EKG and you're going to want to look for long QT. And by that, I mean generally over 440 milliseconds. You also, because many of these medications have significant anticholinergic side effects, you want to make sure they're not taking other anticholinergics like ditropan, for example. And many of the antidepressants, the tricyclic antidepressants, are started at 25 milligrams, typically at bedtime. Probably the most common use you're going to see of this is in the treatment of chronic pain, and nortriptyline is often the favored drug in that case. Now, in STAR-D, they use nortriptyline as their switch agent. So you could switch to a tricyclic, I believe, on the third level of the STAR-D study. And in that case, about 20% of people responded and about 12.5% of people remitted. And typically the doses are going to be between 50 and 200 milligrams. Now, as I mentioned, you can use these for other things such as neuropathic pain and migraine prophylaxis. And historically, they were the go-to drug for what is called melancholic depression. And I'll talk about that more in a minute. But it's important to remember that most all of the tricyclics are actually serotonin norepinephrine reuptake inhibitors. That's what they do mechanistically. It's a little bit of a confusing nomenclature because this is the only drug that we have a category based on its chemical structure and not its mechanism of action. But if you go back to that previous slide, you'll see they have those 3 rings, which is why it's called a tricyclic. Now, some of them are more norepinephrine reuptake inhibitors than serotonin reuptake inhibitors. This would be things like desipramine and nortriptyline. And some of them are more serotonergic than noradrenergic. And the classic on that would be clomipramine, which is still the gold standard treatment for refractory OCD because it's so serotonergic. Now, tricyclics are interesting because they are the one antidepressant that we can actually get blood levels on. This isn't commonly done. It was more commonly done back when they were the standard of care. And there's controversial data about how useful it is. The main thing that they help you to determine is if somebody is getting into a toxic level, which is typically considered over 500 nanograms per milliliter. But they also tell you if you are underdosing somebody. And so, while this isn't commonly done, if it is done, it's probably going to be done with nortriptyline because that has the most established data. Now, what about that overdose risk and the cardiac risk? So the problem with tricyclics is in large doses, they do act as sodium and potassium channel blockers, and this can prolong the QTC. And if the QTC gets prolonged sufficiently enough, this can lead to torsades de Pointes. And that, of course, can lead to a lethal arrhythmia and death. Also because they have that alpha-1 blockade, they can also contribute to hypotension in overdose. And so this is why you want to get an EKG and take a look at this QT segment here. You don't want QT segments that are getting into the upper 400s if you're going to use a tricyclic. And tricyclics get a lot of flack for causing side effects, and that's not entirely unearned. If you break down the different tricyclic drugs here, some examples here, and compare the number needed to treat, which is relatively low, which is what you want to see. So you only need to treat about 2 or 3 people with a tricyclic to begin to see some benefit. And then you compare that to the number needed to harm, separating out minor harm, such as dry mouth or constipation, from major harm, such as arrhythmias, for example. And you can see that these numbers are a little uncomfortably low. I would like to see a number needed to harm closer to 100, quite honestly. That way, the probability of me causing harm is relatively low. So this is one of the reasons why psychiatry has generally tended to veer away from tricyclics. But when you're getting into the realm of treatment-resistant depression, you don't always have the luxury of, you've often used a lot of the different medications. So sometimes you have to get into the less tolerable medications in order to help your patient. Now, I mentioned melancholic depression earlier, and I want to talk about this subtype of depression. So this is a patient of mine, we'll call him John, and he was somebody I treated years ago, and he was hospitalized and for suicidal ideation, and I met him in our intensive outpatient program. And he had probably some of the most profound guilt and worthlessness that I've ever seen, and to the point where he was not eating, and he felt terribly for even wasting my time, and he could not stop that sort of tape loop. And he had struggled with this over the years. In fact, in his earlier life, in his 20s, he had actually attempted suicide by taking cyanide, which was kind of wild. I had not heard that one before. And when he was discharged from the hospital, it was kind of a standard cocktail of a reasonable dose of bupropion, citalopram, mirtazapine, and then they added some atypical antipsychotic of risperidol. So he was on this fairly robust cocktail. And a couple months later, he was still no better. I was thinking about ECT at that point. He decided to stop all his meds on his own, and his guilt and rumination made him not want to restart. And he started getting a little bit better about a month later, kind of on his own, but then he plummeted again. And by mid-January, he was rehospitalized with suicidal ideation. He was discharged on a very small medication regimen of only 100 milligrams of bupropion, but again, was still profoundly depressed and ruminative and just paralyzed with this kind of indecision. He also had this very profound psychomotor retardation. He would kind of pour himself into my chair and had very little affect and very little spontaneous movement. And when we were trying to figure out what to do, he mentioned that in the 1970s, he had had a bout of depression and he'd done really well on imipramine, which is an old tricyclic drug. So I got the idea, I thought, I'd been reading about melancholic depression and had read that tricyclics actually were the gold standard of care. So I suggested that we start him on nortriptyline, which he agreed to. He liked it because it was dirt cheap. It's $4 a month at Target. And he had this slow remission of his depression. So he was still depressed all through that spring. I had considered ECT again, which he refused. And by July, we'd gotten him up to 125 milligrams of nortriptyline, which really did well for him. He remitted on pretty much all of his symptoms and continued well for many years afterwards. So what do we know about melancholic depression? You don't hear this term very much anymore, but it used to be considered to be marked by high serum cortisol and these profound vegetative symptoms, the loss of appetite, disruptions in sleep, profound inability to feel pleasure, and that it could kind of deteriorate into psychosis. And this is what used to be often referred to as an endogenous depression. So it kind of came out of nowhere, as opposed to a reactive depression, which is often in response to adverse life events. And historically, it was thought that melancholic depression responded very well to tricyclic antidepressants, which was my case, and to ECT. And we contrast this to non-melancholic depression, which is typically marked by low mood and anxiety and just a general sense of kind of malaise and unhappiness, and often responds well to SSRIs. So perhaps the ideal tricyclic patient is somebody with melancholic depression who's not elderly. So we have fewer risks of anticholinergic side effects. We have lowered risk of cardiac problems. Somebody who's not suicidal, who's going to go home and take all this bottle medication, has a healthy heart, and maybe even has some other conditions that might benefit from a tricyclic, such as chronic pain or migraine prophylaxis. Now, the reputation of tricyclics having a considerable side effect burden is not unearned, and that's because they have receptor activity on cholinergic receptors, on histamine receptors, and also norepinephrine receptors, particularly alpha-1. And you want to be careful not to combine two highly serotonergic drugs, particularly with an MAOI. So particularly something like clomipramine with an MAOI would be a very dangerous combination and could lead to serotonin syndrome. So that is really pretty much an absolute contraindication. I used probably in my own practice disipramine, which is largely noradrenergic, and nortriptyline, which also is used commonly in chronic pain. So I always get that cardiac history. I take a look at the EKG. There's a chart there. But generally, you want to see QTCs preferably in the low to mid 400s, and certainly not getting up towards 500. And you're going to go slowly to make this tolerable. Now, MAOs are one of these medications that we all sort of have board questions to answer, but probably rarely prescribe. And I'll be honest, I've probably prescribed them less than a handful of times in my 15 years in practice. There was this idea that they worked well for atypical depression, and they were a final option in the STAR-D study, where they did show a modest response in those very refractory patients. And there are two categories of MAO inhibitors. So there are the MAO-A and MAO-B. So Nardil and Parnate are the most common MAO inhibitors, MAO-A inhibitors, and selegiline, which is often used in Parkinson's, is an MAO-B inhibitor. Anytime you're going to switch to an MAOI, you have to get rid of the previous SSRIs because of the risk of causing serotonin syndrome. Because if you recall, what an MAO inhibitor does is it blocks the activity of those little Pac-Man enzymes, which break down serotonin. So if you have an MAO going on and you're keeping more serotonin in the synapse with an SSRI, you're going to have an excessive amount of serotonin, which can lead to serotonin syndrome. So you've really got to wash out that entire SSRI drug, and that's going to depend on the half-life of the drug. For the most SSRIs, they're going to be out of your body in 2 weeks. Fluoxetine is an exception to that because of its active metabolite, norfluoxetine. You're going to need to wait 5 weeks after stopping before you can start an MAOI. And vice versa, you're going to want to wash out that MAOI for 2 weeks before you start an SSRI. And you're going to want to pay attention to other drug-drug interactions because there are many with MAOIs. So you want to be in the habit, of course, if you're using an MAOI, of carefully doing drug interaction checks. There are also food restrictions when you're taking an MAOI. These are all foods that contain the amino acid tyramine. Tyramine is a common amino acid in many foods, particularly aged cheeses and meats, soybeans, for example, certain red wines, certain beers. And The problem with tyramine is that it's normally broken down quite quickly in the gut by MAO, but if you're inhibiting that MAO with these MAO inhibitors, that tyramine acts as a pressor, so it causes blood pressure to go up, and there is the potential for a hypertensive crisis leading to something like an MI or a stroke. So when somebody is on an MAOI, they have to be willing to restrict their diet. Now, what is this serotonin syndrome I keep mentioning? So a lot of different drugs work on serotonin, but if you have too much serotonin happening in your central nervous system, and this can come from obviously antidepressants, but also some pain medications like tramadol have some activity on serotonin, some of the triptans, even linezolide, which is a strong MAO inhibitor. It's an antibiotic, but also things such as MDMA, psilocybin also work on serotonin. There has been serotonin syndrome associated with recreational MDMA use, and also some herbs such as St. John's wort and tryptophan. So serotonin syndrome really exists on a continuum. So very mild serotonin syndrome might manifest as things like akathisia and tremor. This is often why sometimes people with who are using MDMA in a celebratory setting might exhibit kind of a restlessness that they might discharge through dancing. They might notice some tension in their jaw, some trismus, which they might discharge through chewing gum. But as serotonin syndrome progresses, you go into altered mental status, more large muscle clonus, and then hyperthermia, muscular hypertonicity, and you can get into rhabdomyolysis, hypertension, even seizures. So serotonin syndrome can actually be quite dangerous, and this is not something you're going to want to treat as an outpatient. This is always something that is treated in the ER and ICU, because you're going to need drugs like cyproheptadine and dantrolene to manage the serotonin syndrome and the supportive care of probably an ICU. So this is something just to be aware of, but you're probably not going to treat if you're outside of the hospital. So in summary, augmentation is a common way that we first generally address antidepressant failure, and then we go to switching. So I've covered many of the most common switching strategies that you can see here. So I hope this has been helpful to you. Thank you for your attention.